Hello, can you hear me, please?
Yeah, we can hear you. Welcome.
Okay, thank you, and hi, the trainers and dear colleagues, dear India colleagues. It's my pleasure, great pleasure to let me share my. Can you see the screen?
Yeah, we
Can you
can
see the
see the
screen?
screen.
Yeah. Okay. Dear India colleagues, and it's my great pleasure to share my some cases here in our hospital. First case is the patient stenosis, tracheal stenosis with the contact laser. This patient is a female CT4. He was with the soreness of breast for 1 month, and there was a history of the malignant lung tumor. So we did the bronchoscopy, see there was the severe stenosis of the upper trachea, and we also did the biopsy, and the pathologist shows there's the lymphoepithelioma like carcinoma. So the initial diagnosis, the tracheal severe nosis with the lymphoepithelial lymphoma like carcinoma. So here's the CT image. We can see here the very severe stenosis at the upper trachea. And then since this tracheal stenosis caused by the malignancy, so we use the laser with the contact laser to delete the tumor tissue. With the general anesthesis and then we use the laser probe with the contact mode, and then point by point to delete the ablation the tissue. And here we can see the tumor tissue was vapor by the laser. And here you can see there no obvious the carbon or necrosis here. The view was very clear. The diameter of the stenosis was about 4 milliliter in diameter, and with the length of 2 centimeter. So we can here we can almost continuous to ablation the tumor. No many carbon in the on the top on the caster. The V was very clear. So here we can see right now in almost 5 minutes, just 5 minutes, and the cavity was enlarged, and then we with the balloon dilation. Okay. Here we can see the diameter is about 10 millimeter in diameter. And then we insert the mental stent with the Boston Scientific. And then we have the remove adjustment the place. See, we can see the stenosis was the soreness was relieved. So here's the case with the contact laser. And combined with the balloon and mental stent. As we know, the laser classification by medium is solid laser, gas laser, and semiconductor laser, and by the mode of the action, we can divide with the non-contact laser and contact laser. So for this case, we use the contact laser. For the character of the contact laser, as we know, is cutting precise up to 0.2 millimeter, and highly precise laser probe, and it's safe, as we know. For the other laser, it's very high powerful, but with the contact laser, it's with the lateral damage less and less than 0.5 meter, and controllable in cutting rate and depth, and it's also very effective and reduce and so it's price safe and effective. As we for these patients, we use the 15 watts for the laser ablation, And there's another, case two is for diagnosis with the nodule. We use the robotic bronchoscopy and cryobiopsy. Here we can see the CT image. There's a nodule at the right middle side, and then we registration with the robot. And with the calibration. And then under the guidance of the robot, we can get to the nodule base. And here we can see the picture. We control the robot to the nodule. And here we can see there's it's very close and close to the nodule. And after we get to the nodule, and then we use the ultrasound to make sure there's the lesion. There's the place of the lesion. Here we can see the lesion is over here. And after make sure the lesion with ultrasound, and then we measure the length with the forceps and with the cryo probe. And then insert the cryo probe to the lesion and have a cryobiopsy. It's about 7 seconds, and then we take as we know, this is the 1.1 diameter probe. So we have the 6 to 7 seconds of the cryo, and then take the tissue. Here we can see the cryo biopsy tissue, and then have the rows. Here we can see the malignant cell there. So this is the case with the robotic bronchoscopy and combined with the cryobiopsy. For this case, the robot we are using the Chinese-made Polaris bronchoscopy navigation robot. This is the Chinese-made robotic system. It's now available commercially, recently. Here's another case I would like to have the brief introduced. Here's the vocal. This patient after the surgery, the car accident, he got the vocal cord and subglottic stenosis. Here we can see the vocal here, and the stenosis is very severe. And then we put the T-tip but over the vocal. And after 1 year later, you can see here's the vocal, and the lumen is open and remain open. And there's another case is the let me see, it's diagnosed as the pulmonary obstructive infection and also the tracheal obstructive infection. So as we see here, the tracheal collapse here and the right main bronchus, and then we put the bare L-shaped mental stem. Here we can see here is the trachea, and here is at the right main bronchus. And after continuing antifungal infection treatment for 3 months, you can see here the stain is with the contact is smooth. And no granulosities here. So this patient is recently he also follow up. So far he have lived for 5 years. And another patient is the 43-year-old man with the diabetes induced pneumonia. The tracheal intubation and respiratory ventilation was performed in another hospital for 10 days and then discharged. But 1 month after discharge, he got the shortness of the breath and bronchoscopy showed that the tracheal stenosis. And at the other hospital, we can see the multiple balloon dilation in the other hospital and stenosis again. Here we can see the CT image. We can see here's the stenosis very severe at the upper trachea. Here we can see just below the vocal, the stenosis very severe. As for the diameter is about 3 milliliter, and it's about 2.5 centimeter in length. And then we use, as a routine procedure, we use the laser and balloon, but 1 week later, the stenosis narrow again, and then we use the balloon and mental stent. And 1 week later, we remove the mental stent and put the silicone stent with the diameter of 12 milliliter. But 1 month later, the stenosis again, and then we change another stem with the combined stem. Use the lower part is the 12 diameter, and the upper part is the 10 centimeter. And then here we can see 2 months later, the stenosis, the stent was stable. So for this kind of the very upper tracheal stenosis, we recommend that use the short and small mental silicone Dumont stent is the choice, and the effective rate is up to the 85%. Thank you for your attention.
Yeah, thanks a lot. Great cases. Are there any questions from the audience? If not, Shiyue, the new robotic system you showed me, how many cases you performed already? And do you also use cone beam CT during the case?
Yes, so far, thanks, Felix. So far in our hospital, we did almost 100 cases with the robotic. And for diagnosis, we routinely use the ultrasound for make sure the position. But for the treatment, for the ablation, we combine with the combine CT. But for the diagnosis, we just use the ultrasound, the EBAS GS.
Thank you for a great presentation. What is the benefit that you see from the contact laser over the non-contact laser for tracheal stenosis? And the second question is, do you worry about subglottic stenosis with contact laser and the possibility of vocal cord injury?
I think for the contact laser is safer and is efficacy. For the contact laser, you can very precise to make the catheter to the nodule, and then you can control your catheter. If you would like to make deeper, you can have much power. If you would like to the slide, you can just slide contact. So I think it's very safe and also it's very powerful. And the V is very clear. Not like the other APC, the V is not so clear. I think it's the advantage. I'm not sure. I am not sure the second question. What is the second question?
By doing contact laser so close to vocal cords, have you seen any injuries? And then after that, I've seen also a short silicone stent in the upper trachea.
Yeah. Yes. For the very high stenosis of the trachea, we use the small diameter stem. But usually we are not over the vocal, so it's just below 3 to 5.5 milliliter below the vocal. So far it's safer. It's safe.
So how often do you see stent migration in the subglottic stenosis?
Yeah, this is a good question. So at the very beginning, the migration is quite often, but and then now we are getting more and more experience. The migration is less than 20%. The main technique is that not to dilation too large, not to dilation too large before you're putting the stent.
So, Professor Lee, thanks a lot. Great presentation.
Thank you.
Bye-bye.